My presentation is based on the study outcomes of my master's dissertation conducted through the University of Johannesburg in 2012 to mid-2013 under the supervision of Mrs. Barbara van Dijk, and it is titled Compliance of Health Professionals with Patient Confidentiality when Using PECS and RIS. I will commence my presentation with a brief background on the technology of PECS, its role in the medical practice, and the ethical dilemmas associated with it, followed by a summary of a research study from which the study results will be presented and discussed. The limitations of the research will also be highlighted to be considered when examining the conclusions drawn from the research outcomes. And in closing, I will then state the recommendations for both clinical practice and research emanating from the research inquiry. The acronym PECS stands for Picture Archiving and Communication System. PECS is a radiology system purely designed to store radiology images plus radiology reports for easy communications with other departments within a hospital setting through a system of computer networks. The technology of PECS has since replaced the conventional methods of storing radiograph. Some of you may recall that radiographs used to be stored in a huge filing room that was often centrally located. The biggest problem with it, though, was that it contributed to delays in the clinical management of patients that often emanated from the misfiling and the non-retrieval of old radiographs, which often led to repeat radiographs being taken. And not only did it waste the patient's time, it also delayed their clinical management, which led to unnecessary repeat to exposure. However, this problem has since been eradicated through the advent of PECS. Because the radiographs and their reports can now be stored and disseminated electronically, it allows for instantaneous radiology interpretations and secondary medical consultations. For example, in a situation where a PECS system is connected throughout the hospital, it implies that once the radiographer has acquired an X-ray in the emergency room, this X-ray can then be accessed immediately by the radiologist located several meters away for a report, whilst at the same time a specialist who may be equally several meters away from the emergency room can access the same radiograph and start planning and preparing for theatre. It is therefore not surprising that PECS has helped create a basis for teleradiography. What do I mean by teleradiography? This is when two or more hospitals that are in a geographically dispersed locations are connected to the same PECS system, thus allowing for instantaneous access of the same radiograph by different medical specialists for different treatment purposes. Now, the concept of teleradiography is important in places where there is scarcity or total lack of access to services of a radiologist. Therefore, a radiographer in a rural area can send radiographs electronically to radiologists based in Johannesburg in order to access relevant information. Another advantage of PECS is that the digital storage is cheaper than the conventional methods, hence the implementation of PECS translates to reduced storage cost. There is no doubt that the benefits of PECS are profound, but what are the risks and the disadvantages associated with its use? The first and foremost risk associated with PECS is its ability to store data onto the World Wide Web. This now exposes data to the possibility of internet hacking. In general, electronic data allows for increased number of people to have access to data. Moreover, the data can be disseminated in large quantities without the patient's knowledge and consent. Based on this fact, can be deducted then that depending on the various factors, meaning technical, administrative, and human factors, the use of PECS has potential to undermine patient confidentiality because the patient may have little control over who gets access to their information. According to the Health Information Protection Survey of 1993 conducted in UK, it revealed that patients were already suspicious of the fact that their medical data may have been disclosed without their consent, and patients don't like it. This is demonstrated by the fact that 7% of the general public that participated in the survey opted not to consult a health provider in order to avoid the implications of medical disclosures in respect of work and insurance prospects. and for the general preservation of their dignity. This avoidance behavior leads to patients abstaining from medical treatment or giving false medical information, and consequently accessing inappropriate or poor patient care, and thus undermining the very objective of PECS, which is improved patient care through eradication of clinical management. So with this in mind, should we be concerned? As long as we still consider confidentiality to be a human right and necessary for the preservation of human dignity, then the answer is yes. All these technology developments should then concern us. The problem we are facing is that there has been recent reports on the rise of confidentiality breaches involving medical data in the United States, relating to the electronic exchange of patient information, and thus the increased number of people with legitimate access to medical data. The number of breached health records was said to have increased by 97% between 2010 and 2011 alone, and still breaches by authorized users remain an under-investigated issue and continue to threaten the confidentiality of data. It's been 8 years since the adoption of PECS in South Africa since 2006, and yet reports of this nature remain unknown in the South African context. To complicate matters even further, there's talks to advance the PECS technology into cloud computing. By cloud computing, we're referring to a situation where providers of information, in this case health providers, outsource storage and management of their data to a third party. There are two major problems concerning cloud computing. The first challenge relates to the security risks that are heightened by its universal nature, which is in conflict with the location-based nature of the law. It is therefore difficult to regulate the services of the cloud because they pose challenges regarding jurisdiction. Thus, there is a need that exists for the development of privacy laws that are capable of regulating the universal nature of the cloud. And I believe these are underway, except for the challenge that the law often lags behind in keeping with the rapid developments in technology. The second challenge refers to the fact that management of the data stored in clouds is in the hands of professionals that are not bound by medical oath to preserve the patient confidentiality. So, what do we do in response to this knowledge gap and problem? My supervisor and I conducted a quantitative study employing a correlational study design. We did this purposefully to determine the extent to which health professionals complied with patient confidentiality principles when using the technology of PECS and RIS. The study was conducted on health professionals from 2 private hospitals in Johannesburg. The extent of compliance was derived from observed confidentiality practices that were then benchmarked against the stipulated confidentiality practices. We included every willing health professional that used PECS from system for the attainment of either core radiology functions or for the purpose of administering medical care. Owing to the sensitivity of the topic, it was therefore not widely accepted. Out of the 6 hospitals that we had targeted, we encountered a 75% non-participation, with other hospitals telling us that they are afraid of what we may uncover. Nonetheless, we still managed to have a non-randomized convenience sample comprising of 115 participants, including radiologists, radiographers, trainee radiographers, doctors. Most interestingly, nurses also formed part of the study since they had extended license to use PECS by their referring physicians. Questionnaires were hand-delivered by the researcher. The questionnaire consisted of open-ended questions, multiple choice questions, and ordinal data for ranking. The quantified data was then analyzed by a dependent statistician using non-parametric one sample chi-square test to calculate statistical significance, whose correlation was determined using p-values, while the pi coefficient was used to calculate the extent of correlation. So what guidelines informed our study? So what are the stipulated guidelines that drove the study? As a South African study, we first sought guidance from the Health Professionals Council of South Africa, HPCSA. The only guidelines relating to the use of electronic media made references to fax machines and emails, and nothing pertained to PACS. Perhaps this is due to the fact that PACS, the implementation of PACS is still at its infancy stages in South Africa. This finding thus forced us to look outside South Africa for guidance. We came across the 7 standards for PACS confidentiality designed by the Royal College of Radiologists in the UK, the Caldecott principles that used to guide the Data Protection Act of 1998 of the UK, but the most appealing to us was the Health Insurance Portability and Accountability Act of 1996 of the United States. Firstly, the HIPAA is a legislation, a guide that is way out of league to be compared with the HPCSA's ethical guidelines. So why did we decide to use it? We decided that it will be suitable, although its suitability for adoption in South Africa, it will be suitable to use because we took the following advantages into consideration. It is comprehensive since it includes administrative, physical, and technical safeguards. It is the best regulatory rules in existence. It is continually being updated to keep pace with technology, and it has already been consulted for the needs of PACS. And moreover, it is believed that HIPAA has contributed to development of security concepts unique to PACS, such as the DICOM, digital envelope, and digital signature. So what is the role of PACS in medical-related ethical dilemmas? Based on some of the findings of our research, we have identified issues relating to poor access restriction as a factor that leads to an ethical dilemma whereby, firstly, an unauthorized PACS user can be allowed access to PACS data. For instance, an X-ray receptionist who is a member of staff but not authorized to use PACS may gain access to PACS without being asked any questions, seeing that he is a member of staff already. Alternatively, an authorized PACS user can abuse their privilege by downloading data not of patients that they are directly under their care, or by downloading data for reasons other than medical care, e.g. entertainment purposes. Other ethical dilemmas relate to the types of data download and further disseminations, most commonly in the X-ray departments. PACS data is often downloaded on compact disc, paper, or X-ray. However, PACS computers, just like any other computer, have USB ports, and if active, then large amounts of data can be downloaded into USBs or memory sticks. Transfer of data onto smartphones through the use of USBs, Bluetooth facilities, and by simply taking a photo of the image display on PACS is also possible. The role of smartphones in the dissemination of information is more worrying, considering that it can be easily linked to media such as Facebook, BBM, Twitter, and the list goes on. In terms of technical aspects of access restriction, the HIPAA has passed the following guidelines. As we can see in Table 1, the HIPAA mandates for unique identification, and also it mandates that every organization must design their own emergency access procedure. The PACS workstations should be capable of automatic log off after a certain period of inactivity, and the data should be encrypted. We asked questions pertaining to technical security measures employed to restrict access to authorized users. We wanted to find out if the use of passwords was applied properly, meaning, as per the HIPAA advocates, that we must use unique user identifications. The questions were focused on the proper use of passwords, and for these sections, we asked the participants if they used individual passwords or departmental passwords, whereby all members of the department share or use the same password. And lastly, we asked if it was possible for them to access the PACS without requiring any password at all. and whether their passwords were changed on a monthly basis, yearly basis, or not at all. We ask these questions bearing in mind that passwords in particular are considered a popular and easy means of controlling access to data, yet equally they may be the easiest way to breach the confidentiality of electronic data, since their effectiveness is only determined by how frequently they are changed. And this is what we encountered. Only 31, meaning 27% of the participants, used unique passwords to access their PACS system, while 89 participants, or 79% of the participants, accessed the PACS system using a shared departmental password. A further 23% of participants were reported to access the PACS without requiring an access code at all. Only 2% of participants changed their passwords on a monthly basis. Our findings may aid to demonstrate the culture of trust that exists amongst health professionals, which dominate the medical environments, and thus play a role in the issue of technical and physical restriction of access to information. Moreover, although the preservation of patient confidentiality is the foremost benefit of access restriction, it requires the fulfillment of digital security measures that may not be suitable for the hurried nature of the medical emergencies. Thus, frustrated but well-meaning employees may thus find ways to circumvent these measures for the execution of the task. We then went on a fact-finding mission to determine which of the participants were accessing PACS without using access codes, and did cross-tabulations for radiology employees versus non-radiology employees. And guess what we found? As you can see from the bar chart, the green color means yes, and the blue, yes, they can access without password, while the blue color means no, the participants cannot access the PACS without a password. From the bar chart, you can see that the radiology group is represented by the bars to the left of the screen on the x-axis, while the non-radiography group is represented by the two bars to the right of the x-axis. It is therefore clearly demonstrated in this figure that the non-radiology staff members did most of the accessing of PACS system without the use of access code, more than the radiology members. Interesting. We then proceeded to prompt the participants about the log of capabilities of their PACS workstations and their accessibility to unauthorized users in terms of the physical locations of this workstation. And for these questions, we discovered that 3% of the workstations were found to remain active for less than a minute, and that 39% of the cases, the PACS workstations appeared to be located within view of patients and onlookers. These findings indicated poor level of compliance with confidentiality protecting principles in terms of physical and technical security requirements. Next, we proceeded to ask the participants questions relating to the types of data downloads and the modes of downloads. We then deliberately and daringly asked the participants the methods that they use to share patients' data that they found interesting with their friends, with their families, and with their colleagues. So this was a multiple choice question, and they had to choose amongst telling, showing of images, showing of reports, internet transfer, data transfer via BBM and MMS. So considering the sensitivity of these questions, the participants were given an option not to answer this question, provided they say no to the previous question, which said, have you ever accessed embarrassing patient data and shared it with your friends? So for this, the outcome that we found was that out of 115, 48 participants decided not to respond to this question. And the responses, according to the table in the table above, it shows that the radiology employees breached confidentiality by telling and showing in the 27% and 42% of cases, as compared to the 8 and 10% for non-radiology employees. Moreover, employees reported to be only, the radiology employees are reported to be the only group that used the internet in 6% of the cases, and the social networks such as BBM in 2% of the cases, and MMS in 2% of the cases to breach patient confidentiality. In the study, embarrassing patient data stored in the PACS was shared with colleagues and friends, family members for entertainment purposes in 28% of the cases. It is also clear that integrity of the authorized users plays a role in the preservation of confidentiality. To answer the secondary questions about the types of data breaches that occurred, it was evident that showing of medical reports was the most prevalent method. Nonetheless, most of the breaches of confidentiality in the social networks are reported to be unintentional, and the concern is that the number of medical graduates, meaning 4%, were reported to have been found sharing patient information on BBM and Facebook. Therefore, this finding is not unique to the South African setting. When we performed cross-tabulations to determine which method was a popular method for data sharing between radiology and non-radiology departments, we found the following. We discovered that showing of images was the most popular method and mostly more by radiology group than the non-radiology group. The possible logical explanation for this finding is that the radiology may have viewed most of the embarrassing cases because it is their core function to acquire and process radiology images, and therefore they will be more likely to fall for this breach of confidentiality. So from here, we wanted to test if the participants considered their behavior to be a breach of confidentiality, and for this, we blatantly asked them, have you breached the confidentiality of a patient using PACS? And we kept our fingers crossed for answers. So guess what we found? 91% who were brave to answer this question claimed to have not breached confidentiality when using PACS. Now, ladies and gentlemen, this is a big mystery to me, because if they have previously admitted to sharing embarrassing data for entertainment purposes using the various methods for BBM and MMS as were cited, how can then we have 91% of the people who suddenly never have breached patient confidentiality? The low admission rate relating to this deviant behavior is consistent with the literature, which reveals that when asked to answer sensitive questions, participants tend to provide positive self-response. Again, this is mostly the case when people know what the desirable answer should be, and they then tend to give answers that are considered socially desirable. Alternatively, this kind of response may display a tendency to portray oneself in a favorable manner. It is suspected that the reported evidence in the study is lower than the actual behavior. Therefore, the exact proportion of participants guilty of breaching patient confidentiality might never be known for the research settings used in the study. Enough about the limitations of our participants. What were the general limitations that we encountered based on the study design itself and the nature of the research topic? A major limitation of the study relates to the 75% refusal of participants to participate in the study. This reduction in population size imposed further limitations as it forced the researcher to make comparisons on a small sample which comprised of unequal participants, which were thus inhomogeneous. And finally, the lack of randomization implies that the study findings cannot be generalized to the settings outside the participating research settings. So we have to get the results. So we have got the results, and so what? Taking into consideration the results documented in the study, we came to the following conclusions. Stated differently, we learned the following and most two pertinent lessons. Number one, we learned that the preservation of confidentiality relies heavily on the integrity of those authorized to access sensitive information directly. We also learned that the nature of the most security breaches are accidental or unintentional threats caused by well-meaning employees when conducting routine activities. I am sure you would agree with me in saying, had our participants had knowledge of the HIPAA, or had the HPCSA had published guidelines at the time of our inquiry, perhaps the results could have been slightly different and for the better. In the interim, we believe that the following recommendations may partly aid to bridge the gap. We suggested the use of biometric authentication to replace the password use. We suggested that the USB ports be and internet access be inactivated. We discouraged the use of smartphones around the PACS monitors. We also suggested that the security guardian be employed to oversee requests for multiple compact disks from the PACS. We also recommended that policy and training at an organizational level considering the confidentiality issues be provided. And we also recommended that we make HPCSA aware of the fact that we don't have regulations. As for future research, we have suggested that somebody conducts a study to find out if the use of unique passwords is actually suitable for the medical environment. I have come to the end of my presentation, and a long list of references is available on request for those who need it. Thank you for your interest and attendance.